4 hours of CPR in knee-deep snow, a core temperature of 17 degrees Celsius. That's 62 Fahrenheit. A field intubation that fails when the snow swallows her torso at a different rate than her head moves during compressions. And a 24-year-old woman who walked away from it all with zero neurological deficits. Miles' pager went off on April Fool's Day 2014 while loading ski gear into his car. The mission details: female, cardiac arrest, frozen into a tree well 8 hours after she wandered away from a backcountry hut. When he arrived 2 hours later, bystanders had been doing CPR the entire time. The patient was still in V-fib, but Aeromedical wasn't coming to the rescue as the patient didn't meet their criteria. And the current company guidelines were for Miles to take her to the nearest hospital where ground transport could meet them. Him and his team ignored that and convinced a heli ski operation to take them to the nearest ECMO center. Miles is a paramedic and a wilderness rescue specialist who founded Teaam Aeromedical, a nonprofit ambulance service operating across British Columbia. He's lectured internationally on wilderness medicine and hypothermic cardiac arrest in austere environments. This case became the catalyst for building an entire rescue medicine program from scratch, one that cuts transport time to definitive care and potentially saves healthcare systems between $1 and $10 million per patient. We recorded this interview at the FastCan conference where Miles walked through every decision point in this resuscitation, how they managed the airway in the snow, why they defied transport protocols, what happened when they rewarmed her on ECMO, and why getting cold before you arrest changes everything about how we approach these patients. Let's get into it.
You on 8? You on 8. Okay, you're clear. Stand by for your base.
All right, Miles, welcome to Loud and Clear. We just listened to your talk here at FastCan about just a phenomenal case. To use maybe a pun, a heartwarming case. So set it up for us. Tell me about the morning of this call.
So it was a beautiful sunny day, cold winter day. It was actually April Fool's Day. So the result of the case, people didn't believe for a while afterward, but beautiful day, fresh snow. I had been trying to get my wife to get out of the house to go skiing for a couple of hours. And so, yeah, I was stoked to go skiing, and my wife slowed things down a little bit. And as luck would have it, we were still loading up the car with our ski gear when my search and rescue pager went off to let me know that there was a 24-year-old female in cardiac arrest in the mountains.
Oh, and what had happened and what were bystanders doing while you were working to get up to them?
So there was a number of really switched on bystanders up there. They had gone out for their morning ski tour after staying a night in the Elfin Lakes hut. The hut's in a provincial park, and it sleeps up to 30 people. So these people had all been sleeping in the hut, and they noticed that sort of 7 or 8 hours prior, the girl that came up on her own in snowshoes had headed out on her own. And it was a bit of an odd time to head out. So they thought, well, maybe she's just heading back out and she's going to go back home. But as they started skiing, they came across some clothes. They came across like neatly folded clothes, and then came across a backpack, and then heard some moaning and saw a woman's head just above the level of the snow in a tree well underneath a tree. And so they quickly moved over to help her and realized she was frozen, like literally frozen into the tree well, and they had to chip her out with ice axes. And when they pulled her out, she stopped moaning and went into cardiac arrest.
And you talked about this, the irritability of the myocardium we talk about in hypothermia, and we talk about how this can often happen. You're moving a patient and they suddenly decompensate into a V-fib rhythm. But at the same time, you have to get her out of the tree well. How do you reconcile those?
That's definitely the challenge. Is there's no easy way to pull someone into a boat from a lake, or pull someone out of a hole you've dug them out of from an avalanche. The stimulus that we exhibit on the patient by pulling them out is going to have an effect on the myocardium. And it's more, at least at this point, it's more up to us to be able to determine that vital signs are now absent and start CPR as soon as possible. There's an interesting, I talked about Dr. Popsicle or Dr. Gordon Giesbrecht. He's got a study about crevasse rescue currently. And he's found that if they take the time in the crevasse to bring the patient out supine versus, upright, that has a dramatic change on survivability. So keeping someone supine as much as possible is going to help as well. He had a case of a helicopter pilot that fell into a crevasse. Many hours later, they were able to rescue him. He stood up and said he was fine, and then within a moment went into cardiac arrest. And it was the act of standing up and having a cold fluid shift that causes myocardium to become irritable. And so the current guideline is to try and keep someone supine as much as possible.
Interesting. Yeah, tell me more about the thought process behind that. Like, why do they think that occurs?
It's all related to cold fluid shift. So like rewarming shock, if you've got cold fluid in your extremities and it gets all of a sudden goes from not being in flow and all of a sudden it gets the patient gets moving as they stand up, that cold fluid will return to the heart and make the heart colder, thereby more irritable. And all it takes is a little bit of stimulus and the heart will go into a lethal dysrhythmia.
Yeah. I love that point of we have to get that patient out. Yeah. We have to start providing resuscitation. We have to start rewarming. So there's no option. We got to move them. Really, the key point there is recognizing the possibility that they may arrest at that moment and being prepared to act if it happens. Yeah. These bystanders were fairly MacGyverish totally. On scene. Tell me about the things they were able to do.
It was an interesting mix of people. There was a local guy in his 70s who's a big hiker and ski tourer. He passed away this year, but an amazing character. There was a lifeguard. There was a person who used to volunteer for Squamish Search and Rescue. There was someone who works on lifeboats in Germany. There was a Royal Canadian Mounted Police officer off duty. And there was a retired infant transport paramedic in the group as well. And so it was an interesting group of people that all had some fantastic ideas. When they had regurgitation, they decided to make a suction unit out of a water bladder or a hydration bladder, Camelback. When they discovered that the only way that they could get a cell signal out was a kilometer back at the cabin on the second floor deck, they had people every 50 to 100 feet passing messages back and forth to the person on the deck with the cell signal. So lots of really good forward thinking to make things smoother for when we arrived.
Wow. And when did you guys arrive? How long did that take?
2 hours later.
Wow.
So they started CPR. They had to figure out how to get a signal out to be able to call us, and that took some time. And then as volunteer search and rescue is, everything is ad hoc and there's no dedicated helicopters. So we were able to poach a helicopter from Whistler Heli Skiing, and they came down from Whistler with a helicopter and a crew of other volunteers, and they were able to jump in the aircraft and bring that machine down to us. And then they came and picked us up, dropped us off, and then that aircraft had to go back to one of the local bases and reconfigure for a medevac. So it's lots of moving parts for sure.
Yeah. And how long were you guys on scene resuscitating?
About 2 hours.
Okay.
Yeah.
And when you arrived, what did you start doing?
So dragged all the equipment over. It was kind of knee deep in snow. We brought in skis. So I'm lumbering around in ski boots, which are, they're pretty nimble compared to a regular ski boot because we're ski mountaineering. But still, we're moving around in deep snow. Once we arrived, I got a quick report from one of the ski patrollers that was there already, who's an advanced life support paramedic and SAR guy from my team, good friend. And then we decided to make some adjustments, make our treatment plan, and then contact base to get an air ambulance sent to us, which unfortunately was denied because it didn't meet their criteria at the time. So while we were waiting for the aircraft to reconfigure, refuel, and come back, we committed to a treatment plan that included improving the CPR that was happening on scene. They were doing a great job, but they were working, with compressor cycles of about 5 minutes. So we dialed that back to 2 minutes. We started a peripheral IV and then an intraosseous. We're actively rewarmed. We had bystander rewarming. We switched that out real quick and then started using commercial rewarming devices and intubated her, which was intubation in the wilderness setting is quite a bit different than in the urban setting. And so there were some challenges with the intubation. Easy first pass success, but unfortunately when you're doing CPR in snow for a couple of hours, the whole package doesn't move at the same rate. So her torso was being driven into the snow quite rapidly and her head wasn't. And so we kind of surmised that her head kind of changed angle and that extubated her about 40 minutes into the arrest. It was a quick and easy reintubation. Obviously very concerned about her brain because of that, but as it turns out, it wasn't a negative factor in her outcome.
Yeah, there's a couple points there I want to come back to. One is the pathophysiology that you just alluded to in hypothermic arrest, and the other is the challenges of doing CPR in this environment that comes with that. But first, when you're thinking about whether or not to work a hypothermic arrest, what are the factors that are running through your mind with that?
I'm a bit of I like to say I'm an open book, but all the pages are pretty blank. But I'm a pretty transparent guy. When I was given the call details or the mission details, I was like, 2 hours of bystander CPR, we'll do everything we can for her, but I don't think the outcome is going to be positive. Ironically, our team had Dr. Doug Brown come in 2 weeks prior and give a refresher talk on accidental hypothermic arrest. It was his baby, like that's his passion. And so when we got the call, the search and rescue manager, who I will say was probably one of the most heroic figures in the whole thing, because he's got a 2-week first aid course, but he's now talking to doctors and saying, this patient is a special case. We've got to get this patient to ECMO. While we're out in the field doing patient care, he's on the phones to people that are pretty intimidating to talk to, but got Dr. Doug Brown involved and really greased the wheels to get this patient the care that she needed. Yeah. So, a big shout out to the SAR manager.
Yeah. So what were the factors in this case that made you think this is a special case? This person, despite all of the challenges, has a chance at a good outcome.
I think going into it again, I didn't have a very optimistic opinion of what was going to happen, but I knew that she was a hypothermic case, that she had got cold before she went into cardiac arrest. She had rapid bystander CPR and what sounded like quite good bystander CPR. We'd also been told, like, they'd gone through her backpack and found medications. And so they gave us a list of medications, and I was able to clue in and go, oh, you know what, those medications are prone to causing hypothermia. And so it, was a little bit of the clincher in the case that we're probably looking at a hypothermic cardiac arrest. So we won't treat her necessarily the same way as your run-of-the-mill backcountry cardiac arrest if it's a cardiac cause. Yeah. And so, we decided to throw the book at her and see what happens.
Yeah. And talk to me about the pathophysiology of hypothermia and why does this get treated differently?
What's fascinating about hypothermic cardiac arrest, and the full name severe accidental hypothermic cardiac arrest, is it's not truly a cardiac cause like an MI would be. It's a fact of the myocardium getting cold and getting irritable and then not responding positively to a stimulus. So the cold myocardium, we pull the patient out. That stimulus of pulling someone out it's almost like commotio cordis, where someone gets hit in the wrong part of the cardiac cycle and goes into a lethal dysrhythmia. That's exactly what circumrescue collapse is.
What is the importance of, you mentioned cooled and then arrested versus arrested and then cooled?
It's a big distinction, and it's a big difference. If the patient is cooled first, so they got cold first, and then I'm a bit rough when I say it, they got cold first and then they got dead, there's a strong chance of that patient having a viable myocardium, because it's usually an irritable myocardium that's caused that cardiac arrest. The metabolic state is slowed so much that the brain doesn't need much perfusion. The heart doesn't need much perfusion. Like I said in the presentation, for every 1 degree Celsius your core temp drops, your brain needs 6% less cerebral perfusion. So effectively, things are on a little bit of a metabolic pause in accidental hypothermic cardiac arrest. If you go into cardiac arrest first and then get cold, it's a completely different story. The cause of cardiac arrest is different, so whatever the treatable cause is way less likely to be successful, because there's a cold myocardium, there's a hypoxic or anoxic brain, hypoxic or anoxic heart. Your medications aren't gonna bond appropriately, your defibrillations aren't gonna land appropriately. So yeah, that's the big distinction between the two.
What you mentioned, medications that she was on that potentially could put you at risk for that. Do you remember what those were?
I don't remember off the top of my head, but they were antidepressants and that realm of medication.
Yeah. Okay.
It's actually interesting that a lot of antidepressants can make you prone to heat-related emergencies, whether it's hypo or hyperthermia. So
Yeah.
it's a little bit of a side note that's worth looking up if you're a nerd like you and I obviously are. So
Yeah. Tell me about rewarming in the field. Is that important?
it is for sure, more because we're preventing further cooling. So her core temp was 17 degrees Celsius. After 4 hours of rewarming and getting her to the city, she rewarmed to 22, I believe. Not enough to negatively impact her outcome. We have to be more concerned about the patient cooling further than rewarming them quickly with non-invasive.
Yeah. How do you go about rewarming in the field?
So there's a bunch of factors involved. We use Dr. Gordon Giesbrick's hypothermia burrito or hypothermia burrito. So we try and get the patient off the snow as soon as possible. And that's like any trauma in the snow, whether it's someone's been run over by a snowmobile, broken their leg skiing, who knows what. Getting someone off the snow in a trauma is a huge benefit. Obviously, be mindful of aggravating any injuries, but the risk of hypothermia with staying in the snow is much greater than the risk of aggravating an injury by moving them off. So like this weekend, I'm teaching mountain guides a wilderness medicine course, and we're going to use the things that they have in their backpack. So like a sleeping pad, a $10 or $20 sleeping pad could be a lifesaver in someone's backpack. You can make a splint out of it, but what's most important is you can quickly inflate it, get it underneath someone's torso, get them off the snow, and that dramatically increases their chance of survival. And it's such a basic thing.
Yeah.
I carry a guide's tarp, which is just like a sill tarp that's been made specifically for rescue, but super, super thin material, slides easily on snow. That goes as the base. So it gives you some weather resistance, and it's a vapor barrier. Then we put our padding insulated layer. Then we put a blanket or a sleeping bag down. We have another like vapor barrier, like a space blanket. And then we have some kind of rewarming device, whether it's a ready heat blanket or warm water bottles or, not my coffee, but something warm.
Yeah.
And then lastly, what we've done these days, it's fairly new to prolonged field care, but is important to consider is anytime we package someone in the snow, we pull snow into that package. Anytime we've got someone in our care for a long period of time, they're going to lose fluid, whether it's, they needed to be catheterized and we didn't do that in the field, or the fact that they're sweating because we're rewarming them aggressively. All of those fluids need to be collected somehow. And so we put a layer in now close to the skin that'll absorb that fluid so that they're not pooling in liquid, because the chance of bed sores are quite huge, pressure sores. So
how do you time all of that with procedures? Because you're essentially covering up access for IVs, pad placement, those things. How do you time that?
It's a challenge for sure. There's a ton involved with that. We want to make sure that we keep IV access out. If we're going to, let's say that we've started a humeral IO, we'll package a patient. This came from a ski patroller in Nelson, which is a nearby mountain town in British Columbia. But he calls it suplat packaging, which I've now coined the same phrase, which is you package them supine and position them lateral. And so with suplat packaging, as long as I planned ahead to what type of aircraft we're in and what the positioning is going to be, if I put an IO in the right humeral head, I might start an EJ in the right side, and that gives us easier access for medication or fluid administration. Obviously, AP placement for our therapy pads, our ECG leads, we tape in place as well, which is pretty common in flight. We've got to do our best to have access to all of our GAC, but still warm the patient as much as possible. Yeah. When the helicopter comes back into land, if there's like just a tiny crack in your packaging, it's going to fill with snow. And so we have to make sure that we inhibit that as much as possible. One of the things that we'll use is we'll create our own microclimate around the patient and us by putting a bivy sack or a bothy bag over the top of the whole package. Something we got to be careful with because we don't want that to go up into the rotor disc. But if you do it right, especially if you've bought a bothy bag, which is custom made for rapid shelters in the mountains, you can secure that and it won't go into the rotor disc, and it stops all the snow from getting blown into the patient packaging.
You mentioned when you guys were doing CPR that her torso started to sink into the snow.
Yeah.
Do you have any tips on doing CPR in the snow?
One thing I'll say, because I'm level 53 now, which when I hit 50, I stopped counting by years. It's now levels. So I've achieved level 53 as opposed to I'm now 53. But now that I'm level 53, when I hit 50, they're like, your knees are going to start hurting. Here's your antihypertensives and here's a pair of glasses. Doing CPR in the snow feels so good on my knees. Because you're dealing in ice pack. But the big challenge with this particular case was that, her whole body wasn't moving the same in the snow. So we want to make sure that we package a patient well so that their head and neck move at the same rate as their torso does. Obviously, we want to get them off the snow as quick as possible. We will often dig a bench. So we'll dig a bench in the snow for the patient to be in that bench off a slope and not in a place where wind transport's going to take more heat away. And then I'll dig a lower bench for me to kneel in so that I'm comfortable and the patient's kind of at a good height. So we always have avalanche shovels in our gear when there's snow on the ground. And those avalanche shovels get used more for digging a table to work on a patient than digging somebody out of an avalanche. So
you guys were on scene for about 2 hours.
Yeah.
And not much changed with your treatments. What treatments did you provide? You said you intubated.
Yeah, so we stepped up the CPR a little bit with compressor cycles every 2 minutes instead of 5. Stepped up the rewarming. Didn't have to have skin-to-skin rewarming anymore. And then, quick intubation. Started a peripheral IV and then an IO. Defibrillated. The guidelines now suggest 1 defibrillation. And if I were to do that resuscitation again today, I would just defibrillate her once, knowing full well that we need to get her somewhere that's going to warm the heart. In that case, with John and I looking at that beautiful coarse VFib, I was like, oh man, I just want to convert that.
It's hard not to hit that button.
Yeah. So we were like, I bet the guidelines weren't written for a 4-hour resuscitation. So let's defibrillate every 15 minutes or so. It was a decision we made at the time that I wouldn't repeat now based on what we know now. But there wasn't a negative outcome. We just know that she needs a warm myocardium before she needs defibrillation.
Yeah.
So
and epinephrine.
Yeah, gave her some epi every few minutes. I think in total we gave her 3 doses of epinephrine, so a milligram Q. And these days I might give her 1. Yeah, 1 dose, 1 milligram, and know that because she's cold in the snow and hypothermic, she's already pressed. She doesn't really need medication to be pressed. There's downsides to epinephrine, as we all know, with the brain. That downside isn't there for the hypothermic patient who's pressed because of the cold.
Yeah. So there wasn't much change in what you guys were seeing from her. She remained in VFib, but you're still seeing electrical activity in the heart. And so you initiate transport. Where do you go?
So we were told by the ambulance dispatch center to take her to the nearest ambulance, and then they would take her to the nearest hospital. We knew that she needed to get to ECMO. And so we decided to temporarily rewrite the rule book and get her to an ECMO center in Vancouver, which was a bit of a flight from the scene away, but not so far as to be detrimental to her patient care. So we got her to Vancouver General, to the ECMO team that was waiting there. They were obviously pretty excited about the case because they got a phone call from Dr. Brown. Fortunately, by the time we made the phone call and got her there, it was just after lunchtime, and there was an ECMO case booked for after lunch, but the call arrived when the ECMO team was having their lunch break, and they were like, oh yeah, we'll bump this next patient to get your patient in. So the ECMO team was available, the equipment was there, the staff were there, and they were able to get to her. I think she spent 4 minutes in the emergency department and then went up to ECMO. So
yeah, and what did they do for her?
Rewarmed her real fast. Yeah, they rewarmed her from 17 degrees in the field, 22 degrees by the time she got to the hospital. They rewarmed her to 37 degrees in about 20 minutes. They do admit that was a little fast and that they do it a whole lot slower if they were to do it again. But after rewarming her to 37 degrees, they defibrillated her once and got ROSC.
Wow.
Yep.
Why is that important to rewarm maybe in a more slower, controlled manner on ECMO?
It's just, the amount of control and mitigating negative side effects. There was a few challenges with her outcome. I do think the epinephrine played a part in her having a poor ejection fraction. and perhaps some myocardial stunning with having a few defibrillations. Not that there were that many, but so yeah, that taking their time to rewarm someone slowly is going to be much safer.
Yeah. So they rewarmed her, and first shock, she converts and they get ROSC. Which I guess highlights the point of the heart needs to be warm to be able to respond to that defibrillation. How'd she do after that?
For the first few hours, not so well. Her brain was working well, which I was ecstatic about, because with the field extubation, I was quite concerned about that. Her ejection fraction was 5%. It was terrible. And so when they tried to wean her off ECMO at 2 3/4 hours, her EF was enough that they decided to reinitiate it. And she was on ECMO for a few more hours before her ejection fraction kind of resolved. And eventually they were able to wean her off ECMO. It was within a few hours anyway. She was within a few minutes of ROSC. She was biting on the tube. Within a few minutes of extubation, she was singing. She had a bit of a raspy voice, but she was singing. It was, an absolutely incredible outcome for sure.
Wow. Yeah. What an amazing outcome. You mentioned in your talk, how much cardiac output does somebody who's hypothermic need based on their metabolic demands?
Not a lot. So the literature that I've most recently read suggests about 25% of normal perfusion is needed for a hypothermic patient. So even poor CPR is going to be of benefit. Obviously, we need to do the best job we can of good chest compressions, fresh compressor. But when it comes to the hypothermic cardiac arrest, their metabolism is slowed so much that they don't need the same level of perfusion.
This is such a phenomenal case with such a phenomenal outcome. But I know anytime there's a big case like this, we always sit back and reflect. After reflecting on this case, is there anything you would have done differently or changed?
Yeah. Lots of things for sure. I would have had one more coffee before I headed out, because it was quite a few hours. Would have taken a change of clothes, because you imagine doing CPR in Gore-Tex for hours. But really, when it comes to medical treatment, I would have only defibrillated once. I would have only given one dose of 1 milligram of epinephrine, packaging her a bit more firmly so that her head moved with her torso. And that's about it.
Yeah.
Yeah.
And after this case, and it sounds like this entire year for you was fairly pivotal in where you are now.
Yeah.
Tell me about that.
2014 was a catalyst, pivotal year for sure. In January 19th of 2014, my friend Tim, he was my station chief with the ambulance service. He was my team leader with North Shore Rescue and a friend of 20 years. He passed away in the mountains in North Vancouver, basically just off the side of a ski run. And I was assigned to his cardiac arrest with another team guy that was on a different ambulance. And as we arrived, we were told there's a new policy change and we're not allowed to walk up the trail to get to his side. I will say that I've walked that trail with my pregnant wife. I've seen people in their 70s and 80s walking their dogs on that trail. But because of high risk hazard risk mitigation policy that had just come into place, we weren't allowed to walk up the trail. So we, unfortunately, by the time Tim was brought to us, we threw the book at him, but he didn't respond to treatment and ultimately did pass away. He was an incredible guy. He was the grandfather of wilderness or mountain rescue medicine in British Columbia, created a powerhouse search and rescue team of volunteers, great station chief. He was a real character. Like, we called him Knuckles because he was a little bit of a Neanderthal. I hope they don't think I'm a bit of a Neanderthal, but I have those tendencies sometimes. But an amazing man, and he had a huge heart and did so much. So it was devastating when he died. I've got a tattoo in his memory. I'm still good friends with his family, in contact with them regularly, and they're really quite happy with what we've done in Tim's memory. So January 19th, we lost Tim. April Fool's Day of the same year was this hypothermic arrest case, where we rewrote the rule book for that case, and she survived. We followed the rules with Tim, and he didn't. And so we decided to build a program where wilderness medics could get to patient side in the most austere settings. We approached government on it. They didn't want to take on the risk. Both levels of government that we approached had different perspectives of the risk. One was medical legal, one was physical workplace risk, and said no. And so we decided to build our own program. So we built a nonprofit wilderness air ambulance program. It's called Teaam Aeromedical, it's a bit wordy, but Technical Evacuation Advanced Aeromedical Society, or Team with two A's. So we employ paramedics, nurses, doctors, respiratory therapists, mountain guides, and rescue specialists, including firefighters and search and rescue volunteers. They're all employees within our program that can respond to emergencies. We've got 4 bases currently in British Columbia, Squamish, which is head office. That's where I'm from, Campbell River, Prince George, and Revelstoke. 2 of them are mountain rescue bases, Squamish and Revelstoke, and they can respond and back up the staff in the non-MR bases. We do helicopter hoist and fixed line rescue. So we're, the dope on a rope kind of rescue. We do auto extrication, mountain rescue, avalanche rescue, and depending on the base, like for example, our Campbell River base, we're getting into hyperbaric medicine, fundraising for a portable hyperbaric chamber. So we've got specialty medicine at different bases as well. So our nurses, paramedics, doctors work with the rescue specialists to safely operate in that terrain, and be able to get the patient to whatever is the most appropriate center as quickly as possible. In reality, we take time to definitive care and divide it by like tenths. So the example I'll give is our first ever patient. The patient that they had a few weeks prior took them 14 hours to get to definitive care. We can get that same patient to definitive care in an hour and 40 minutes. So it's a dramatic difference in time, a dramatic difference in outcomes, dramatic difference in the medical economics of things as well.
Yeah, it's getting the right providers to the right patient at the right time and taking them to the right location.
Yeah. We recently were called to the traditional Canadian lumberjack response, where this guy had fallen 25 feet off a cliff, had laid by himself for 2 hours before one of his coworkers found him. And we ultimately long-lined him out of a waterfall. So we got long-lined into a little bench on the waterfall. When I say a bench, it's like a little piece of rock that we could do patient care on. Secured ourselves to that, packaged him, medicated him, long-lined him out. The other option would have been to set up a rope rescue system, and it would have taken multiple hours to get him out. And we had him out in a fraction of that time. So that's the kind of meat and potatoes of what we do. We do a little bit of repatriation work. So we've been to Bali and Mexico and the States. And we do some interesting fixed wing work where, for example, we had a motor vehicle rollover of a road building crew out in a logging operation. So we dispatched a rotary crew to provide patient care, and we dispatched an auto extrication crew by fixed wing so that they could fly over more quickly, land at the airport, meet the rotary crew, fly into the scene, do the auto extrication, and then fly the patient out. So it's a bit of a planes, trains, and automobiles kind of operation, but whatever it takes for us to get the right patient care and rescue modality to the patient, we're going to figure it out.
Nice. That's amazing. And you figure you're able to save a fair amount of healthcare dollars just by getting patients better care faster so they suffer less complications. That leads to more treatment they need.
Yep. So on average, we save between $1 million and $10 million per patient. All we do is life and limb threats. So it's all high acuity stuff. We're not doing anything that isn't a life or limb threat. The head injury retrieval trial, or the HURT trial out of Australia a few years back, they were able to determine that for traumatic brain injuries alone, a team that was able to provide advanced skills or critical care skills on the scene, they actually found that they spent more time on the scene, did more procedures on the scene, and then transported directly to the most appropriate facility. And that resulted in dramatically lower injury types, lower injury size, and shortened recovery time and shortened stay in the ICU. And they saved on average, and again, just for traumatic brain injuries, $4.3 million per patient savings. So better outcomes for the patient, which is first and foremost, but millions of dollars in cost savings by doing pre-hospital care properly.
Yeah, that's amazing.
Yeah.
Where can people go to learn more about you?
We're at www.teaam.ca.
Perfect. Awesome. Thanks so much.
You bet.
What a phenomenal case. Strong work out there. Long time to be doing CPR and caring for somebody, but man, what an outcome.
Thank you.
Thanks for coming on.
You bet. Good to meet you.
Yeah, you as well.
17 degrees Celsius, 4 hours of field CPR, 1 failed intubation mid-resuscitation, and a woman who woke up in the hospital singing. That outcome doesn't happen by accident. It happens because Miles and his team understood the physiology, challenged the protocols when it mattered, and got her to the right place instead of the nearest place. Let me give you the guiding principles that made this save possible. She cooled first and then arrested. This is the single biggest distinction in hypothermic cardiac arrest. If your patient got cold and then went into arrest, their myocardium is irritable but viable. Their metabolism has slowed so dramatically that their brain needs 6% less perfusion for every degree Celsius their core temperature drops. Even mediocre CPR can be enough. But if they arrested first and then got cold, you're dealing with a completely different problem. Hypoxic and anoxic tissue that is unlikely to respond to intervention. Know which scenario you're managing. Second, limit your interventions because the heart has to be warm to convert. Miles gave multiple doses of epinephrine and defibrillated multiple times in the field. Looking back, he'd give 1 dose of epi and shock once and move on. The myocardium is unlikely to respond until you rewarm it. And when you're cold, your body is already maximally vasoconstricted in an attempt to shunt all of the blood to the vital organs. They rewarmed her from 22 to 37 degrees on ECMO, shocked once, and got ROSC immediately. That's your answer. 1 round of interventions, and if that doesn't work, then hold off until you can get them warm. Get them warm, and your shocks and medications are more likely to be effective. Next, keep them supine if you can. When cold fluid from the extremities returns to the heart, it can make the myocardium more irritable. Standing or moving a hypothermic patient can trigger lethal dysrhythmias. Miles tells a story of a helicopter pilot who fell into a crevasse, got rescued hours later, stood up and said he was fine, then arrested immediately. Observational studies have also demonstrated that when they take the time to rescue someone from a crevasse, supine, rather than upright, their outcomes are better. If you can keep your patient horizontal from the moment you reach them until they're rewarmed, that's ideal, but realize you're in an austere environment. You can't stay there forever. And sometimes the best or only option is to move out of the environment. So it's a risk-benefit balancing act. You got to do what you got to do. Just be prepared for the possible adverse outcomes so you're ready to act if they do occur. Package them off the snow. A sleeping pad, a vapor barrier, insulation, a rewarming device, another vapor barrier on top. Get them off the snow or they'll keep losing heat. Dig a bench for the patient and a lower bench for you to kneel on while you're doing compressions. Plan for preventing snow from getting blown into your packaging when the helicopter arrives. Use a bivy sack over the whole package to create a microclimate. Transport to the right facility, not the nearest one. Miles was told to take her to the nearest ambulance, then the nearest hospital. He knew she needed ECMO. His team flew her directly to the ECMO center where the team was waiting for her. That decision may have saved her life. If you don't have the ability to rewarm on bypass, your severely hypothermic arrest patient is less likely to survive. And finally, plan for failure. The field extubation happened because her torso sank into the snow at a different rate than her head during CPR. Miles was concerned about her neuro outcome because of it. Thankfully, she had 0 deficits, but that moment reinforced something critical. Know your backup plan before you need it. Have your equipment ready. Practice the transitions. When plan A fails in the field, plan B should already be figured out. This case changed Miles's career. Just before this save, his friend Tim died on a trail that Miles had walked with his pregnant wife. Policy at the time said they couldn't go up that trail to reach him. They threw the book at Tim when bystanders finally carried him down, but he didn't make it. 3 months later, Miles rewrote the rules for this 24-year-old woman, and she survived. That contrast pushed him to build Teaam Aeromedical, a wilderness air ambulance program that cuts transport times, saves healthcare dollars, and employs paramedics, nurses, doctors, and rescue specialists who can actually get to patients in austere environments. You might never work a hypothermic arrest, but the principle underneath this entire case applies to everything you do. Know the physiology, challenge the protocols when they don't serve your patient, and get them to the right place at the right time. This is the maximally excellent care your patient deserves.